DW Africa Link.
Malawi's health workers are facing a tough choice. President Peter Mutharika has signed an executive order banning public health workers from owning or operating private clinics or pharmacies, a practice known as dual practice. They now have to comply or risk losing their jobs and facing legal action. So what prompted this move, and what ripple effects could it have on Malawi's already stretched health system?
I think the directive has no basis. It is illegal and the infringement of human rights. How can the president say that? How and why? With the way Malawi is now, I think we are encouraged to have a side hustle.
The directive is quite okay because here in Malawi, we've seen that sometimes you might go to the public hospital and you will not find any medication there, and they will refer you to go to a certain hospital or to a certain pharmacy.
That's what's coming up. I am Eddie Micah Jr., and you are welcome to Africa Link, the podcast connecting you to the stories that matter.
Africa Link, every weekday here on DW.
The president signed the executive order after an investigative report exposed corruption in public hospitals. Illegal fees for services meant to be free, medicine diversion, and doctors allegedly steering patients to their own private clinics for faster treatment. The government says this is about integrity and fairness, but doctors are pushing back, saying the ban oversimplifies the problem. They argue that salaries are modest and many rely on private work to make ends meet. So what is the real problem here? Let's break this down with Maziko Matemba, a health analyst who is also the executive director of Health and Rights Education Program. That's a local NGO promoting health and rights for Malawians. I also have DW correspondent Chimwemwe Padatha in Malawi. Hello and welcome to Africa Link. Chimwemwe, tell us more about this directive and what really triggered it.
I would say that the Malawi president really made a directive barring health workers from owning private clinics or pharmacies. So by making this directive, the president has just acknowledged that the health sector has been riddled with corruption, just to say that the directive is coming at a time when patients in public hospitals are asked to pay money to access services that are meant to be free. And sometimes these patients are asked to buy medicines at pharmacies. But surprisingly, most of the pharmacies people are referred to are owned by these health workers working in public facilities. So in brief, this is what has triggered the directive. I also point at an investigation that was done by a team of some investigative journalists led by one renowned online publication, which released an expose on corrupt practices in government hospitals. So in this investigation, this team of journalists singled out cases that happened in refill facilities involving not only nurses or doctors, but also the support staff in hospitals. So a few days after the publication of this investigation, the president acted by issuing this directive. These two issues are what have triggered the directive, and now the health workers have 30 days to strip themselves off from private hospitals ownership. So in brief, that's what I can say, Eddie.
Thanks for that. And look, I've tried my best to explain what we mean by this dual practice thingy, but you're on the ground in Malawi. Can you give us briefly exactly how it's been working in Malawi? Throw some more light on that.
I would say the dual practice really appears like something which is a cartel in the health sector, because presently nurses, doctors, and other workers in the public facilities own either a pharmacy or a private clinic. Apart from working in the public facility, they operate these two separate entities. So mostly you find a doctor or a nurse spending more time at his or her facility, unlike the government hospital. So we have seen cases where a doctor is issuing a prescription to a patient and directing that patient to a particular pharmacy he owns to buy certain medicine. So the medicine, which is also supposed to be free at the government hospital, is being bought at a nearby pharmacy directed by a doctor or a nurse. So it is really quite a sad situation, because these private pharmacies or hospitals have also become a platform for abuse, where the health professionals end up diverting medicine in other pharmaceuticals to their private clinics, unlike having these items in the public facilities.
Right. Thanks for adding more to that. So I'm just wondering why many health workers still feel that it is essential, that is this dual practice, because from what you're describing, that's not good, is it?
Yes, it is really not good because they are risking lives of Malawians, and they feel it is something which is good on their side because they are trying to earn a living. So when they have a private clinic or a pharmacy, they are adding on their salary. So some of the health workers I've talked to are arguing that they receive low salaries. That's why they resort to owning a private clinic or a pharmacy to make more money through their private businesses, unlike spending more time in a public facility.
Interesting. Thanks, Chimwenwe. Let me come to you, Maziko. What do you make of such a sweeping executive order on this issue, and what do you make of the issue overall?
I've been around in the Malawi health sector from the early 2000s, and this sweeping executive order has come about, as what Chimwenwe has mentioned, because there's a history behind it. Because I was there in the early 2000 when the Minister of Health, Government of Malawi, with support from the British government and other stakeholders, had these. We had a human resource crisis or emergency, where we so many professional health workers leaving the country after being trained. That was the time when Malawi had the new university. We called it the College of Medicine. Now it's called KUHES, and that time it was just producing few numbers. So there was a decision which was made as a temporary decision at that time, because that's why I said it's got a history, that maybe at the moment, since the university is new and it's only training not many professional doctors or professional clinicians or nursing, why can't we have these a temporary measure of making sure that these staff or these new professional health workers, they can have dual practice. Practicing from public but also private. But as I mentioned, it was supposed to be a temporary that time because the numbers are very few. So it was supposed to be reviewed over time so that we can see whether the numbers are growing, but also looking at the perception, but also the client satisfaction from the hospital. So over time, it has been a query, and most of the public has been complaining that this dual practice is causing more harm than good, because most of the professional health workforce, despite staying in the country, not going outside Malawi for practice, but they are spending more time, as mentioned, to their private practice.
So you support that sweeping executive order on the issue?
Yes. Representing the clients. That time, it was supposed to be reviewed. That temporary measure was supposed to be reviewed over time and see whether it is working or not. Unfortunately or fortunately, it was not reviewed until now. And what has come up to be is what now the executive order is trying to address.
So this was essential and important many years ago, and it was supposed to be reviewed, but it wasn't. At what point did it turn ugly? So much so that the government is using an executive order to end it.
As far as the first 5 to 10 years since this temporary measure was made, it started turning ugly slowly. Because we started having these new graduates who most of them were not there, because the challenge which we're having now, most of the graduates who are now graduating from our local university, a public university, they have no knowledge of what really happened, because it has been a long time. So because of this retention of having the new ones and the old ones are leaving or they're retiring, there were never such a conversation, because this issue was never been discussed. So most of them thought it was a policy that once they enroll into public service, more especially the specialists and the clinicians and the doctors and some nurses and the pharmacists, automatically they need to open up a private pharmacy or a private clinic. But that's why, for me, our core will have been that people need to handle this soberly, because they need to look at this history, which I'm sharing now, so that they should appreciate what really happened. Because you can also see to it what I'm sharing now, that both sides could have supposed to sober up and able to say, is this working or not? And why is it making that most of these professional workforce, they're no longer interested to work where they're supposed to be employed. That is the public service, and they're more to do into their private practice. The review, even from the doctor's side themselves, they were supposed to make a review on whether, or maybe they're still making challenges, so that this could not reach this far, where now the investigative journalists came about, and also the clients were complaining that once they go to public service, they are not meeting this professional workforce. They're busy working in their private clinics.
Right, right. Thanks for that, Maziko. Chimwemwe, what's been the overall reaction? Let me guess. Mixed reactions, or are all on the same page that this is the right move for the government?
There's a really mixed reaction on the ground, but mainly there's a growing uproar within the health profession on this issue. Just to make it clear that in the past few days, several bodies, such as the Medical Doctors Union of Malawi, the Society of Medical Doctors, and others, have indicated plans to engage the Ministry of Health on the same issue, while others have since said that they will take court action against the directive. And these bodies mainly argue that a blanket restriction on ownership or shareholding in a private health facility by government-employed health workers infringes on economic rights, and it has a possible disruption of essential services in the health sector. So I can say that the health workers have grown frustrated over the directive, because the operation of private clinics or pharmacies means additional income on top of their government paychecks.
What risks does the medical community foresee with this policy, especially concerning staff retention and specialist shortages, which has always been a challenge?
One of the issues that keeps coming out is that the medical community foresees a future that lacks innovation in the medical sector, as they say that ownership or running private clinics goes a long way towards improving health services in the country. So some of the workers in the health profession claim that while the intention of curbing corruption is commendable, the directive will also see Malawi's health system collapsing as a result of the directive. So from what I've established, the medical community is generally worried over what might transpire and how their lives will be like after the 30 days period that they have been given to stop operating or owning private clinics or pharmacies. So generally, they are saying that their future is a bit hazy. That's what I can say, Eddie.
Maziko, the government's aim was to reduce malpractice and bribery. So is this government move going to achieve that?
Well, it's interesting. It's very, very interesting for me, because starting following the health sector since early 2000, to be more precise, 1998, and some of the reforms has taken over time. Fortunately, by God's grace, have been around. For me, I'm looking two ways. One is an opportunity for medical family that they can also take this as an opportunity to engage government, what they have started, how they can improve their working conditions in public facilities. Because as I'm talking now, there are so many reforms which government, we as even stakeholders, we have proposed to government. And one such is the living condition of our medical professionals. So we are looking at that as an opportunity for engagement, that not all can open a private clinic. Because if you look at what Chimwemwe has mentioned, not everyone can open a private clinic. In fact, if you can do our study, you find out of all the professionals, not all of them are owning those private clinics, because you also need to have capital, you also need to have resources. So you could see even within the medical fraternity, there also might be some who might be being found not happy, because maybe they're working longer hours, because their friends, they have good opportunity and capital to run clinics and pharmacies. So for us, it's back, but it's an opportunity for the reforms which were being pushed, and some of them were not moving, because some of these critical professionals were busy practicing private, owning a good sum of money, but their friends were working over hours, and they were also being affected, and they were complaining of the working condition in government setup. And one such of reforms which have been proposed is that maybe we have optional paying services, because currently our healthcare system, I would have said at the beginning, is free at the point of care since 1964. So we were also proposing that we have optional payment services within our public health services, so that those who are willing to pay, those who are medical insurance, they can go to pay, and those resources should be used at that facility where they're operating. So we believe if indeed those resources equitably have been shared and have been used, I think you can also try to improve for who are working in that facility.
Look, the elephant in the room, and I like using that term, I don't know why, but it just sounds good to say, is that Malawi already faces a shortage of health workers, right? Many doctors rely on private work to supplement relatively low public salaries, as both of you have highlighted. So if you remove that income stream, some may leave the public sector entirely, right? Isn't that a concern?
Yes, it is a concern, but some of them they use and they've got a clientele, customer clientele over time, because 2005, to be more precise, is a long time. Some of them who have been that older. They can also have a clientele within the public where they're trusted to run those facilities and earn some money working in that clinics privately. And the others who are new graduates, because I also am fortunate that I'm the council member for the Kamuzu College of Health Sciences. So we have huge numbers of new graduates who are failing to be absorbed into the system. And most of them, 3 or 5 years ago, they're still not being employed by government because the government cannot match in terms of the recruitment of those. So that's why I say it's a mixed bag, because currently the graduates are increasing, the medical graduates and before. So that's why I'm saying it's a mixed bag. And the question is how it can be managed, because we're also looking at the clientele satisfaction, but also we're looking at the professional workforce satisfaction. So we have to balance both sides, other than looking at one side, because the clients are also complaining, and the Chimwemwe can be my witness. If you go to our facilities, they're not seen by anyone. They're seen even by low-ranked professionals who have no clue on how to treat the patient, because these professionals are not there. They're busy operating in that facility.
From what you said, it really begs the question for me, is the government fixing accountability or risking an even bigger staffing crisis?
Yes, government is risking. I can agree with you that government is risking, at the same time trying to fix the accountability. For us, I think the best way for our medical professionals, because this is an executive order which can be debated and engaged, as has been said. The question is, how can they assure the government that they will be there in the facilities and treat patients as far as they also operating? Because there's so many issues which also are coming: issues of accountability, issues of theft of some medical commodities, and all those which also rampant because of this problem which we had over time. So we are looking at both sides. And in fact, this is the test for our health system, Malawi, on how we can be resilient and moving forward. It's a big test for government.
It is indeed, because look, again, critics say the real issue is weak oversight, staff shortages, and systemic corruption, problems they believe cannot be fixed by a blanket ban alone. What do you say to that?
That's why in our statement, in our government statement, we have meant in the preparation of this executive order to have a special task force that can bring on board all the affected stakeholders, so that and agree, because we're talking issues of sustaining the healthy workforce in Malawi so that they should not migrate. At the same time, we also try to fix the accountability. So I believe that assurance can come not having a blanket order, but having an engagement within the two parties, so that they agree. If indeed government is saying they're going to soften up on the executive order, but what assurance are we getting from our professional workforce that they'll be there and operate, and also avoid these accountability issues which the communities and patients are complaining about?
Right. Thank you very much, Maziko. Chimwemwe, can Malawi strengthen public health care without pushing doctors away?
I think Malawi can strengthen public health care, as you have said, without pushing the doctors away. What matters is just to put proper guidelines and policies, and take into consideration issues affecting Malawians, because now the issue that we are talking about, this directive, has really excited most patients, Malawians on the ground, because they have faced challenges for quite a long time. Many other times that they have gone to a public facility, but they do not find drugs, issues of shortage of health workers, and some have been forced to dig deeper into their pockets because of this issue of corruption. They're asked to pay for services that are meant to be free. So I think it's a matter of having proper policies and guidelines and treading carefully on this issue that has been mentioned, that has been the directive that has just come out from the president.
Right, because as you say, yes, workers have 30 days to comply with the executive order banning public health workers from owning or operating private clinics or pharmacies. Either the 30 days to comply or risk dismissal and legal action. So, Maziko, what needs to happen now moving forward to ensure that the core of the problem in the health sector is addressed?
Yes, for us, I think to tackle this problem is that we have this task force that the government and the affected health workers who are running these private clinics to engage and then agree on how this can be done, because what the public is waiting is the assurance, even we as advocates. We're waiting for the assurance where the public will be able to enjoy having a luxury or being treated by a professional workforce who's not absent. So that assurance will be critical for us, even with this executive order. That's what we're looking for. That's what is the public is waiting for after this executive order. So we believe that one is critical on our side. At the same time, government also should be mindful that these are professional health workforce, which has to be treated well, and they has to be compensated well. So that one also has to be done, and how it can be done. If the reforms which have been proposed in increasing more money for health, domestically and globally, that also be another way so that their livelihood is improved. Because we don't want to be seen that our health professional forces have migrated when we know we have shortages around the country.
Right. Well said, both of you, to wrap this discussion up. Maziko Matemba, health analyst, and DW correspondent Chimwemwe Padatha in Malawi. Thank you both very much.
You're welcome. Thank you, Eddie.
Thank you so much for having me to this important conversation. Thank you.
Africa is changing. Don't get left behind. Tune in to Africa Link.
Health workers warn that removing that extra income will risk resignations, migration abroad, and an even deeper brain drain in a country that already has one of the lowest doctor-to-patient ratios in the world. Their argument is that the real issue isn't dual practice itself, it's weak oversight and poor management within the system.
I think the directive has no basis. It is illegal and the infringement of human rights. How can the president say that? How and why? With the way Malawi is now, I think we are encouraged to have a side hustle where someone can have an extra income. I don't have any problem with that as long as they are going to work. After knocking off, they can go back to their private businesses. I don't have any problem with that.
I do not agree with the executive order that medical doctors working in government should not operate private clinics. Right now, 90% of these medical doctors are the ones that have private clinics and actually improving health service delivery in our country. So I believe that there can be another way to ensure that our doctors are efficient, our doctors are available in our government hospitals, but not literally prohibiting them from operating private clinics.
The directive is quite okay because here in Malawi, we've seen that sometimes you may go to the public hospital and you will not find any medication there, and they will refer you to go to a certain hospital or to a certain pharmacy, which these workers are on that particular pharmacy. So they normally advise you go there and find this medication. So when you go there, you find that particular drug. So the directive is good.
Dual practice exists because governments can't pay competitive salaries. Experts say that if Malawi wants this reform to work, it needs balance. That's better incentives for public doctors, clear regulation rather than a blanket ban, stronger oversight, and real dialogue with the medical community. Because anti-corruption reform without a strategy to retain health workers can easily backfire. Ultimately, it's the patient who pays the price. Share your thoughts with us on Facebook at DW Africa. Listen on Spotify or wherever you get your podcasts. And subscribe to our DW Africa YouTube channel so you never miss an episode. This show was co-produced and edited by Isaac Mugabe, and I am Eddie Micah Jr. Thanks for listening.
DW. Made for minds.